Hello friends, I'm Dr. Ajay Adv. So today we are going to discuss high expected questions for your next upcoming exam, that is December 2022. So these questions I have tried to frame based on the pattern of the questions asked in your previous exams, and secondly, very importantly, what are the very important changes on recent advancements or recent updates on which you can expect a question. Question number one, true statement about this cylinder. It carries the gas Entonox. The pressure is 2000 psi, used for labor analgesia, all of the above. So this is Entonox, and Entonox is a mixture of, Entonox is a mixture of 50% oxygen and 50% nitrous oxide. So the color of nitrous oxide cylinder is blue. So therefore the body of Entonox is also blue, and there is oxygen also. So this white quadrant that indicate oxygen. So that is why the color of Entonox cylinder is blue body with blue and white quadrants. As far as pressure is concerned, pressure is 2000 psi. And why 2000 psi? This 2000 psi pressure is actually the pressure of oxygen. Oxygen pressure is 2000 pounds per square inch. So whenever you mix a gas with oxygen, or in fact when you mix two gases with different pressures, the mixture always exhibit the pressure of higher gas, and that is why Entonox is exhibiting the pressure of oxygen, that is 2000 pounds per square inch, while that of nitrous oxide is 760 pounds per square inch. And the main use of Entonox is for labor analgesia, painless labor. So this is a mask. Through this mask, this parturient patient, she will keep on inhaling Entonox. And the second use, dentists, they are also using this Entonox to produce dental analgesia. So all of the above is true. And D, all of the above is true. Question number two, a sick patient in ward needs supplemental oxygen. It will be given from which of the following cylinder? You can look at the images. A, this is B, this is C, and this is D. Okay. So now regarding cylinders, two most important things that you should know. One is the color and second is the pressure. These are the two very important things about cylinders that you should know. Color and pressure. So let's see color and then we'll discuss pressure. So color is not only important from questions point of view, color is also very important from clinical point of view, because color is the criteria to identify a cylinder. So color of oxygen cylinder is black body with white shoulders. Black body with white shoulders. Nitrous oxide is stored in blue color cylinders. Then third, which is a combination of oxygen nitrous oxide, that I told you is Entonox. So Entonox color is blue body with blue and white shoulders. So these are the three most important color of the cylinders that you should know, and I think that should be more than enough. No need to remember that of heliox, air, other. Second thing is pressure. Regarding pressure, there are many units you will see being used, and many units are used in different parts of the world. Pascal, kilopascal, M bar, atmosphere, so many units are being used, but of course you need not remember about other countries, you have to only remember about India. And India, two units which are used are kilogram per centimeter square and pounds per square inch, psi. So you can remember in one unit, and if required you can convert it to other unit. So 1 kilogram per centimeter square is equal to 14.5 psi. 14.5 pounds per square inch. So in a full oxygen cylinder, the pressure is 2000 pounds per square inch, which if you convert in kilogram per centimeter square divided by 14.5, so it will come around say 139 or 140 kilogram per centimeter square. Nitrous oxide, the pressure is 760 pounds per square inch, and Entonox, already we have discussed, the pressure is 2000 psi, that is the pressure of oxygen. Now with this background, now we'll again have a relook at this question. Patient need oxygen. So how will you identify by color? So this is a color, that is black body with white shoulders, with white top. So this is oxygen cylinder. So answer is obviously A. This is blue. Obviously this is nitrous oxide. And this already we have seen that it is a blue body with blue and white shoulders, that is Entonox. And this is carbon dioxide. So carbon dioxide is not used in anesthesia. However, this carbon dioxide cylinder you will see as gray, but that is not used in anesthesia. Still you will see carbon dioxide cylinders in operation theatre being used for gas insufflation for laparoscopic surgeries. The significance of the following part of anesthesia machine is it ensures that wrong gas is not delivered to the patient. It ensures that high pressure is not delivered to the patient. It prevents the static current. It prevents leakage of the gases. Now what is this? Another very important thing about cylinders that you should know is the pin index system. So pin index system is not only the part of cylinder, it is the part of cylinder as well as anesthesia machine as a combination. So more or less it is a part of anesthesia machine. And the part of the anesthesia machine which contains this pin index system is called as yoke. So this is yoke. So yoke is that part of the anesthesia machine where cylinders are fitted. So it has pin index system. So it has two pins. So there are 7 pinpoint positions which has been described. 1, 2, 3, 4, 5, 6, 7. Now we say that pin index for oxygen is 2 and 5. That means the two pins at the yoke of oxygen will be at a position of 2 and the position of 5. Now at the same corresponding distance, there will be holes in oxygen cylinder. Like here, now we say pin index for nitrous oxide is 3,5. That means at the pin of nitrous oxide, at the yoke of nitrous oxide, the two pins will be at a position of 3 and the position of 5. And at the same corresponding distance, there will be holes in nitrous oxide cylinder. Now say I consider this yoke as of nitrous oxide. Means nitrous oxide cylinder will be fitted here. So what will be the pin positions of these two pins? One will be positioned at a position of 3 and second will be positioned at a position of 5. Now at the cylinder of nitrous oxide, it is on the other side. You will see that there are two pins which are positioned at 3 and 5. So only nitrous oxide cylinder will be fitted here. You cannot fit oxygen cylinder because pins and holes on the cylinder will not match. So if the pins and holes will not match, so how will you fit the cylinder? So it's very important to prevent a wrong fitting of cylinders. So this is what, this is actually pin index system, and the aim of pin index system is to prevent the wrong fitting of cylinders. And pin index position for different gases, you have to remember. Oxygen, the two pins are placed at a position of 2 and 5. Nitrous oxide, these two pins are placed at a position of 3 and 5. And Entonox has only single pin at a position of 7. Fine. So now we can look at the question. The significance of this part of anesthesia machine. It ensures that wrong gas is not delivered to the patient. So pin index system ensures that wrong gas is not delivered to the patient because it can be catastrophic. By chance, if somebody places nitrous oxide at the place of oxygen and patient receive 100% nitrous oxide, patient is definitely going to die. So this is a very important protective mechanism to prevent the wrong fitting of cylinders. The following circuit can be used for 5-year-old child undergoing appendectomy, 2-year-old girl for IND with spontaneous breathing, 10 kg boy for hernia repair, all of the above. Now regarding circuits, I will tell you that circuits basically can be classified as open. What is circuits? Circuits are the tubings which deliver anesthesia gases from anesthesia machine to the patient. So circuit may be open circuit, means you directly deliver inhalation agent over patient mouth and nostril. So it was more or less used for ether in the past, or chloroform you can give by open method. But open method you cannot control the depth of anesthesia, and when the patient is expiring, patient expire into the atmosphere, that can cause significant theater pollution. So open circuit are not used. So nowadays we are actually using semi-open, semi-closed and closed circuits. So here let's first discuss semi-open. Semi-open circuits were described by Maffelson, so they are called as Maffelson circuits. Maffelson circuits. So Maffelson A is also called as McGill circuit. McGill circuit. So it is like this. It is like this. So this is the machine end which will be connected to anesthesia machine, and this is the obviously patient end which will be connected to the patient either through mask or through endotracheal tube, and this is the expiratory valve, and this is the breathing bag which you will use to ventilate the patient. So inspired gases coming from anesthesia machine are called as fresh gases. So fresh gases coming from anesthesia machine will be delivered to the patient, no doubt. Now the expiratory gases, which I am drawing here as blue dotted lines, most of these expiratory gases will went out into the atmosphere through this expiratory valve, but some of these gases will go back into the tubing. Now the gases which has gone back into the tubing will be re-inhaled by the patient. That is called as rebreathing. But aim of every circuit is that there should not be any rebreathing. And how to prevent this rebreathing? The fresh gases coming from anesthesia machine should be sufficient enough first to push these expiratory gases out of this expiratory valve and then to be delivered to the patient. So fresh gas recommendations for McGill circuit is that if you are using it for a spontaneously breathing patient, spontaneous ventilation, then fresh gas flow requirement should be equal to the minute volume of the patient. Means fresh gases coming from anesthesia machine should be equal to the minute volume of the patient. If you use for controlled ventilation, this fresh gas flow requirement becomes very high, more than 3 times of the minute volume. That's obviously not acceptable. So therefore, McGill circuit is not recommended for controlled ventilation, or more or less you can say it is a circuit of choice for spontaneous ventilation. B and C, there were some changes which was made by Maffelson, but those changes were not acceptable. So B and C became obsolete, no more used. Now Maffelson D is like this. This is for fresh gas flow. Now fresh gases will go through this. However, it was not effective, but a modification in this was made by scientist Bain. And what modification he made? He actually incorporated an inner tube into this outer tube. Now you can see that fresh gases will go through the inner tube and expired gases through the outer tube. So there is no mixing of gases. That's why this circuit become very popular, so and so that you can say that Bain's is the most commonly used semi-open circuit. Semi-open circuit. And fresh gas flow recommendations for Bain's, if you are using it for controlled ventilation, fresh gas flow should be around 1.5 to 2 times. So average you can say is 1.6 times of minute volume. If you use it for spontaneous ventilation, fresh gas flow requirement is high, and that is 2.5 times of minute volume, which is high. So it is not preferred for spontaneous ventilation, or other words, you can say it is a circuit of choice for controlled ventilation. So until these are adult circuits. while methylation E and methylation F are pediatric circuit. So methylation E is just nothing, that is just an iris T piece, just a T piece. To this, a tubing was attached by a scientist iris, making it an iris T piece. But it's not a complete circuit because it does not have breathing bag. So it was made complete by attaching a breathing bag to it by scientists Jackson and Rees. So Jackson and Rees, which is also called as methylation F, is the most commonly used pediatric circuit. Most commonly used pediatric semi-open circuit, and it should be used in children less than 6 years of the age or less than 20 kg. Less than 6 years or less than 20 kg. And fresh gas flow recommendations are similar to Bain's. Fresh gas flow are similar to Bain's, that is 1.6 times for controlled ventilation and 2.5 times for spontaneous ventilation. Now let's go back to our question and see. Now first you have to identify which is this circuit. This is Jackson Rees. How? You can see this is a T piece. To this T piece, a tubing was attached by a scientist. So this is actually T piece. So this T piece, a tubing was attached by a scientist iris. So iris T piece. Then a bag was attached by scientist Jackson and Rees. So that becomes Jackson Rees circuit, which is most commonly used pediatric circuit to be used in children less than 6 years of the age or less than 20 kg. Now we can look at the choices. Since you have identified say Jackson Rees, so 5-year-old child undergoing appendectomy, yes, less than 6 years. 2-year girl for IND with spontaneous breathing, yes, it can be used for spontaneous breathing, however not preferred. Fresh gas flow requirement will be higher but can be used. Then 10-year-old boy for hernia repair, yes, 10 kg, not 10 year, 10 kg. So it is, I told you, less than 6 years or less than 20 kg. Means can be safely used for 10 kg boy only. So all of them. 5. All of the following agents can produce toxic compounds with the following circuit except trilene, sevoflurane, isoflurane, desflurane. So this is basically closed or semi-closed circuit. I'll tell you why. Now the definition of semi-open circuit is that fresh gas flow requirement should be more than or equal to minute volume. And all semi-open circuit we have seen fresh gas flow requirement is either equal or it is more than minute volume. For closed and semi-closed, obviously needless to say fresh gas flow should be less than minute volume. So this is a fresh closed, I'll first say closed circuit and then I'll tell you difference between closed and semi-closed. This is the inspiratory part and this is the expiratory part. So fresh gases from expiratory part will go to the canister containing soda lime. So this soda lime will absorb carbon dioxide from these gases and these gases can be reused. So the same gases are in circulation. So actually nowadays they are called as circle system. I mean the same gases are in circulation. We will say it closed if all gases they are completely absorbed by soda bicarb and completely after soda bicarb absorption the same gases can be completely reused. That's not possible. Soda bicarb is not always 100% effective and there are many joints you can see where there is a possibility of leakage. So some gases will be leaked. So practically all this closed circuit we are using are actually semi-closed. So closed is just a, you can say, theoretical concept. But still the fresh gas flow requirement is less than minute volume. So the advantage is when you compare with the semi-open circuit, the advantage of circle. So nowadays that is why they say they avoid this terminology, in fact closed and semi-closed, and simply they use circle system. So circle system, the advantage is the same gases can be reused. So consumption of gases is less, so they become more economical. and since gases are not venting out into the atmosphere, so there is less theater pollution. Then, but the disadvantage is that some of these inhalation agents, they react with soda lime to produce toxic compound, and the most classical example of that was trilene. Trilene, by reacting with soda lime, could have produced toxic compounds like dichloroacetylene, which could have damaged cranial nerves, could have produced phosgene gas, which can cause ARDS. But this is a matter of past, because now trilene is obsolete for decades and decades. Even in my life, I have never seen trilene. But that's a matter of past. But the agent which we are using nowadays, they can also react with soda lime to produce toxic compound. For example, sevoflurane. Sevoflurane, by reacting with soda lime, can produce a toxic compound called as compound A, which is nephrotoxic. Although the production of compound A is very rare, nowadays more or less you can say a theoretical phenomena, but yes, it can produce compound A. Then problem if soda lime become desiccated. Desiccated means dry. Then it can really cause havoc. With the desflurane, it can produce carbon monoxide poisoning. In fact, with other agents also, but mainly with the desflurane, you can say. While with sevoflurane, it can cause burns of respiratory tract. But fortunately, soda lime become desiccated is very rare nowadays, because when carbon dioxide react with soda lime, water is produced, and moreover, water is also instilled in the soda bicarb. So now we can look at the question. All of the following agent can produce toxic compound in the following circuit, except circuit is circle system. Trilene can, sevoflurane compound A, and desflurane can cause carbon monoxide. So answer will be isoflurane. True statement about the following method of ventilation. Its definite method of ventilation can be used for long-term ventilation. It is associated with the high risk of aspiration, all of the above. What is this ventilation? Ventilation with a mask. So ventilation with a mask can be used only as a tied over phase till you are able to achieve definite airway. Definite airway means when you are placing a tube in trachea, then we say that we are ventilating patient with definite ventilation. So that means endotracheal tube, that is intubation, and tracheostomy only constitutes definite airway. Anything which is not placed in trachea cannot be considered as definite. So of course, mask ventilation cannot be definite method of ventilation. And another disadvantage of mask ventilation is that it is very tiring. You try somewhere with mask ventilation, you really cannot keep ventilating with mask for more than few minutes. It becomes very tiring. And you can imagine, they see the holding of the mask is an art. Three fingers are holding and lifting the mandible, and thumb and index finger is holding the mask. So it is tiring, very tiring. So it can be used only as a tied over phase till you are able to achieve the definite airway, means you have to intubate the patient. Then one of the biggest disadvantage of mask ventilation is increased risk of aspiration, because you are giving positive pressure ventilation with the bag and mask. So that will lead to leakage of gases into esophagus, and that will lead to gastric distension. And when the gastric distension is there, you know that then LES become ineffective. If the pressure becomes more than 20 centimeter of the water, that makes LES to become incompetent, and patient can aspirate. So one of the biggest disadvantage of mask ventilation is increased risk of aspiration. Now we can see the true statement. It is definite method? No. It can be used for long-term ventilation? No, only for very small period. It is associated with high risk of aspiration? Yes. So C. Also about the following laryngoscope. It's video laryngoscope. Success rate following field direct laryngoscopy is less than 50%. Both of the above, none of the above. So obviously it is video laryngoscope. So laryngoscopy may be direct laryngoscopy. Direct means you do laryngoscopy and then you directly look into the patient oral cavity, and under direct visualization you do intubation. While in video laryngoscopy, you need not look directly into the patient oral cavity. There's fiber optic cables which will take the image from this video laryngoscope, and this image of the larynx will be displayed on the screen. Your screen may be a video laryngoscope screen. You can use any of a computer screen, or you can use even smartphone screen too. So the advantage of video laryngoscopy is that it really makes difficult intubation easy. In fact, there has been studies that with video laryngoscopy, the chances of success can be as high as 90 to 95% if you are filled with direct laryngoscopy. So it can improve the success rate by around 90 to 95%. So look at the question. It is video laryngoscope? Yes, that's correct. Success rate following field laryngoscopy is less than 50%? No, it is more than 90 to 95%. So obviously other options also become ruled out. So it's a video laryngoscopy. No, they are the false statement, not the true statement. B. Not true. It's video laryngoscope. This is true statement. But in the question they were asked false statement. So B is wrong. Success is more than 95, 99%. Then direct laryngoscopy, laryngoscope is like said, same. And the most commonly used laryngoscope for direct laryngoscopy, is Macintosh. Macintosh, which has got curved blade. This is Macintosh. Actually, it is Macintosh, but in direct laryngoscopy, there will not be fiber optic cables. There will be bulb, and you have to directly visualize the patient vocal cords. So Macintosh is the most commonly used laryngoscope, and it is preferred for adults. However, can be used for pediatric also, but preferred for adult. The second laryngoscope that is nowadays commonly used is Miller, which has straight blade. Straight blade with little curve at the tip. So it will be largely straight but with little curve at the tip, and Miller is preferred for children. Pediatric age group, but doesn't mean that it cannot be used for adults, but it is not preferred for adults. It can be used for pediatric patient, but definitely not preferred. So this is very important. If they ask you laryngoscope blade of choice for adults, it is obviously Macintosh. But if they ask you for children, it is Miller. And pediatric any age, in books you may find that many pediatric laryngoscope blade being mentioned, and previously they were using also, but for now all pediatric age groups we are using Miller. Question number 8. All of the following are the advantage of the following equipment except: decrease the risk of aspiration, very useful for failed intubation, good for cervical spine fractures, avoids complication of intubation. What is this? Laryngeal mask airway. LM. Laryngeal mask airway. If you ask me one equipment in which maximum advancement has been made in or in terms of equipments, maximum advancement has been made is related to laryngeal mask airway in last one and a half decade or 2 decades, and LMA has completely revolutionized the anesthesia practice. So LMA, I'll show you first the classical LMA. This is the classical LMA, which is placed in oral cavity blindly, so that this cuff part lies in oropharynx or hypopharynx. So when you inflate with a large volume of air, this cuff will get inflated, and when the cuff get inflated, it will seal the oropharynx or hypopharynx from all sides. Now, if you ventilate through this hole, you can see this ventilation ports. Through this ventilation ports, air has no option but to go to larynx. So when LMA was manufactured, its main use was for alternative method of ventilation for failed or difficult intubation. alternative method of ventilation for failed or difficult intubation. But over the years, when they started to use LMA, they found it to be so effective method of ventilation that now they are using it electively. For elective ventilation, we are using. Initially, they were using it only for small duration surgeries. Now they are using even for moderate or even long duration surgeries also. So what is the main advantage? Avoid complications of intubation. It avoid complications of intubation. Then other advantages, that is the major advantage. Other advantage, it is an easy procedure. Even paramedical staff can insert it. So it is easy technique. Does not require laryngoscope. Laryngoscope not required. And then it does not require any specific position or a head and neck. Otherwise, you know that there is a specific position for head and neck, but it doesn't require any specific position. So can be placed in any position of the neck, can be easily placed in neutral position, making it very useful for cervical spine fractures. But nothing in the world has only advantages. So there's a disadvantage also. And the biggest disadvantage of LMA is that air can leak from the sides. See, it is not blocking the esophagus. It is resting over the esophagus. So air can still leak from the sides, can increase the intragastric pressure, increasing the risk of aspiration. So biggest disadvantage of LMA is that there is increased risk of aspiration. And another problem is not only that, you are clearly seeing that air is getting leaked from the sides and patient's stomach is getting distended. You cannot deflate also. How will you deflate? From where you will pass your suction catheter Rayleigh tube, because cuff has occupied the oropharynx or hypopharynx. So from where you will pass your suction catheter Rayleigh tube. So you cannot even deflate the stomach. But this is not a problem with second generation LMA. Nowadays, actually, we are using second generation LMA, and the advantage of second generation LMA is that there is a separate port for stomach deflation. And the prototype of second generation LMA is ProSeal. So this is in fact ProSeal LMA, and you can see that there is a separate port for stomach decompression. So from this port, we will enter our Rayleigh tube or suction catheter, and then through this tube, through this hole, it will enter the esophagus and you can deflate the stomach. Now with this background, now we can look at the question. All of the following are advantages except. So this is ProSeal LMA. Decrease the risk of aspiration? No, it increases the risk of aspiration. Very useful for failed intubation? Of course. Good for cervical spine fractures? Yes. And avoids complication of intubation? Yes. So A is untrue statement or wrong statement. Question number 9. Which is not the desirable maneuver for the following procedure? Flexion at neck, extension at neck, extension at atlantopistal joint, all of the above. What is this? This is intubation. Laryngoscopy and intubation. So what should be the position of neck during laryngoscopy? If I ask you, I know your reflex answer would be extension, but actually that's not wrong. That's wrong. We actually have to achieve extension at atlanto-occipital joint, and at neck we have to achieve the flexion, and this is called as morning sniffing position. So morning sniffing position is extension at atlanto-occipital joint and flexion at cervical spine, which is the most desirable position for intubation. And this can be achieved by simply applying a 6 to 8 centimeter pillow below the occiput. A pillow or a ring is applied just below the occiput and you automatically achieve this position, that is morning sniffing position. So which is not a desirable? Of course, extension at neck is not desirable. So morning sniffing position is extension at atlanto-occipital joint and flexion at neck or flexion at cervical spine. So answer is B. Maximum oxygen delivery, and these are your equipment. You can see A, B, C, and all delivers equally. Okay, this is very important, and in fact, during COVID, it actually has become more than important because during COVID, the crisis of oxygen made us to learn the importance of oxygen. We should not waste the oxygen. So we should actually know that how much oxygen is provided by which kind of equipment. So we can see oxygen delivery devices. Maximum flow and maximum delivered oxygen. So first start with nasal cannula. This is nasal cannula. Maximum flow you can keep is 6 liter per minute, and this is flow per minute. 6 liter, and at that maximum oxygen you are getting is 44%, or you can say 0.44. FiO2 is 0.44. Then simple oxygen mask, maximum flow which you can use is 10 liter, and at that you expect 60%, that is 0.6. Oxygen mask with reservoir, this B. So this is a simple oxygen mask, and when you attach this reservoir bag, it becomes oxygen mask with reservoir. Maximum flow you can use is 15 liter, and that maximum oxygen you expect is 80% or 0.8. This is Venturi mask. See, with Venturi mask, maximum flow you can use is 15 liter, and the maximum oxygen is 60%. Now what is the difference between this 60% and this 60%? Venturi masks are accurate, means if you set 60%, they will deliver 60%. And how it is decided? By these Venturi devices. So this is a Venturi device. If you see the color purple, it is written 15 liters per minute and 50%. So if you use purple layer instead of blue, it is definite that it will be 50%. So now you can see maximum among these, and that was our choice, maximum oxygen delivery, ABC. So it is maximum is with oxygen mask with reservoir, that is 80%. B. So answer is B. Which of the following anesthetic agent is best for cardiac patients? Halothane, isoflurane, nitrous oxide, sevoflurane. Most cardiac stable inhalational agent is isoflurane. Isoflurane. So best for cardiac patient is isoflurane. Best if I ask you for respiratory patients, respiratory means asthma or COPD. Inhalation agent preferred will be sevoflurane. Why? Because sevoflurane causes maximum bronchodilation. For hepatic patients, we again preferred sevoflurane. Why? Because sevoflurane causes minimum decrease in hepatic blood flow. And for renal patients, the most preferred inhalation agent is desflurane. Why? Because desflurane does not produce fluoride, so it is safest for renal patients. Which of the following structure is not encountered during epidural anesthesia? Supraspinous ligament, interspinous ligament, ligamentum flavum, dura. So this is very important and very favorite question of FMG. Very frequently asked that what are the structures which are encountered when you are giving spinal or epidural. So this is just two spines. So this is anterior and this is posterior. So obviously we will be entering from the posterior side. So first to encounter obviously will be skin. Below skin will be all this subcutaneous tissue. And then is the supraspinous ligament. Supraspinous, which connect the tip of spinous processes. Then is the interspinous which connect the spinous processes. Then is the ligamentum flavum, which is called as yellow ligament of the body. And then is the dura. And adhere to the dura is arachnoid. So there is actually no subarachnoid space. That is why as soon as you pierce the dura, you also pierce the arachnoid. So spinal anesthesia is given here in subarachnoid space. And that is why spinal anesthesia is called as subarachnoid block also. While epidural anesthesia is given here, that is between dura and ligamentum flavum, and that is why it is called as extradural. Epidural is also called as extradural because we are injecting drug outside the dura. So during spinal structures encountered skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura and arachnoid. And during epidural structures encountered skin, subcutaneous tissue, supraspinous, interspinous and ligamentum flavum. So dura and arachnoid obviously will not be punctured during epidural, and that is our question. Which structure is not pierced, not encountered? So that is dura, D. Anesthesia in MI patient is best maintained on. In MI patient is best maintained on oxynitroxide halothane, oxynitroxide isoflurane, oxynitroxide sevoflurane, oxynitroxide desflurane. Very important thing I like to tell you over here is that previously, as I told you, that inhalation agent of choice for cardiac patient is isoflurane. So what they were telling is it is the inhalation agent of choice for all cardiac patients except MI. And why in MI they were not using? Because it can cause coronary steal. But it is very well proven fact that nowadays that it is proven that isoflurane does not causes coronary steal. So isoflurane does not causes coronary steal. So does not causes coronary steal. So can be used for even MI patients. So nowadays isoflurane can be used for all cardiac patients including MI, while previously we used to say it can be used for all cardiac patients excluding MI. Now it can be used even for MI patients. So in a MI patient, anesthesia will again be maintained with isoflurane. However, if patient ejection fraction is low, then we don't use inhalation agent because all inhalation agent decreases cardiac output including isoflurane. So in that case, anesthesia will be maintained with opioids. So forget about that. You can just remember that now isoflurane can be used even for cardiac patients including MI. A 26-year female suffering from PIH has to undergo LSCS due to fetal distress. Anesthesia of choice: spinal epidural, combined spinal plus epidural, GA. You know that for decades and decades we were theoretically saying that anesthesia of choice for PIH patient is epidural. Why not a spinal? Because these patients are uncontrolled hypertensive, so after spinal they'll go in sudden hypotension. And why not GA? Because otherwise also GA we avoid for pregnant patients because of the increased risk of aspiration. You know that the risk of aspiration in a pregnant patient can be as high as 8 times more as compared to the normal patient. And in PIH patient there is an additional reason that there is laryngeal edema. So but practically we were using a spinal because practically it is not possible to give epidural in emergency situations because onset of action of epidural takes around 15 minutes. So you cannot wait for 15 minutes in case of situations like fetal distress. We have to take the baby out as fast as possible. So therefore theoretically epidural was not used, but since It was being mentioned in books, so we were saying epidural, but now recommendation also says that anesthesia of choice for PIH patient is spinal. So again, this is something new on which you can expect a question. Anesthesia of choice for PIH patients is now spinal. A 50-year-old female is posted for thyroidectomy. She is a known case of hypertension for 5 years on irbesartan. Regarding her antihypertensive medication, stopped immediately. Dose reductions are required. Continued only morning dose of the morning, omitting the morning dose. Stop a day before surgery. This is again a very important change. Actually, all antihypertensives are continued except AC inhibitors and angiotensin receptor blockers, which need to be stopped a day before surgery. And this is, I can even mark with green pen because this is a recent advancement, a day before surgery. In books you will see it is given that they should be just omitted on the day of the surgery. That was previous recommendation. So all books for this question you will find answer being given is omit on the day of the surgery. Yes, that was there, but the current recommendation is that we have to stop a day before surgery. Why? Because if you continue, they found that they can cause significant hypotension in intraoperative period. 16. This is done too. Ease of oral intubation, ease of nasal intubation, both none of the above. What is this? This is Mallampati classification, which is done to assess the mouth opening. So what do? We simply ask the patient to open mouth as wide as possible, and looking at the structure seen, patient has been classified into 4 categories: 1, 2, 3 or 4. If majority of the, you need not go in details that which structure are seen in class 1, which is seen in class 2, class 3. But just you can say in class 1, you are able to see all these structures like tonsillar pillars, hard palate, soft palate, fosses, everything you are able to see. Means if you are able to see everything, it means mouth opening is adequate. While in class 4, you can see you are not able to see anything. Not able to anything means mouth opening is restricted. So of course for class 1 and class 2, mouth opening is adequate. So oral intubation is easy. While class 3, mouth opening is restricted. So oral intubation will be difficult, but still you will be able to manage. Class 4, nothing is seen. So obviously oral intubation is impossible. So either you have to go through nasal intubation, or that is even if not possible, then you may even need to go for tracheostomy. Fine. So this is actually done to see the easiness of oral intubation. Mallampati classification. Question number 17. The following graph will be seen: exhausted soda lime, defective wall of closed circuit, both of the above, none of the above. What is this graph? This is capnograph. One of the very important thing you can say in respiratory monitoring is capnograph. And capnography is the measurement of end tidal carbon dioxide along with the graph. So normal graph would be like this, that CO2 is touching the baseline. The next breath again it will be like this, it will be touching the baseline. So say this is maximum around 37, 38 and say this is 0. So this is the normal graph. But here what you are seeing is that EtCO2 is not touching the baseline, it's not coming to 0. It's not coming to 0, not touching the baseline. What does that indicate? That indicate that patient is inhaling carbon dioxide. And a patient is inhaling carbon dioxide means soda lime is exhausted. What will happen? CO2 will not be absorbed and it will come to the inspiratory side and patient will inhale carbon dioxide. Or if this valve become defective, then CO2 will not be adequately reaching the canister. So not reaching the canister means not getting absorbed, so it will be retained in the patient inside, patient body. If more CO2 inside, so obviously exhaled CO2 will also going to increase in our monitoring. So now look at the question. Exhausted soda lime will lead to inhalation of carbon dioxide and CO2 will not reach baseline. Similarly, if there is a defective wall of the closed circuit, that also will lead to inhalation of carbon dioxide and it will not touch the baseline. So both of the above. 18. This equipment cannot detect methemoglobin, sulfahemoglobin, fetal hemoglobin. What is this? This is obviously pulse oximeter. So this is pulse oximeter showing the pulse as well as oxygen saturation. So all these pulse oximeters which we are using nowadays, they cannot detect abnormal hemoglobin. Whether it is methemoglobin, sulfahemoglobin, fetal hemoglobin, sickle hemoglobin or any carboxyhemoglobin, they cannot detect abnormal hemoglobin. So they are not accurate if there is a presence of abnormal hemoglobin. So to detect abnormal hemoglobins, we have to use co-oximeters. So co-oximeters are the special kind of oximeters which can detect abnormal hemoglobin, while our normal pulse oximeters cannot detect abnormal hemoglobin. So they'll not be able to detect all of these abnormal hemoglobins. So the following injection is contraindicated in. This is what? Propofol. Egg allergy, soy allergy, both of the above, none of the above. Propofol is very commonly used. In fact, it is the IV induction agent of choice nowadays. Why? Because of its shorter half-life. But the disadvantage of propofol is that injection is painful. Why? Because it is prepared in soybean oil. Then it contains egg. So it contains egg lecithin. So what is the disadvantage of egg lecithin? That egg, is a very good culture media for bacterial growth. So there is chances of contamination. In fact, there has been death report due to the use of contaminated solution of propofol due to septicemia. But now, since the presence of egg or soya makes it contraindicated for egg allergy patients or soy allergy patients, no. It is safely recommended for patients who are allergic to egg because it contains lecithin which is prepared from yolk and egg allergy is always from egg white albumin. So it can be safely used. Similarly, though it contains soybean oil, but there has been no case reports of allergy being reported in the patients who are allergic to soya. So patients who are allergic to soya or egg can safely receive propofol. So answer is none of the above. Respiratory rate per minute in a 5-year-old child undergoing advanced life support is 10, 20, 25, 30. This is a very important change in 2020 American Heart Association CPR guidelines. Previously, for children as well as adult, the breathing rate was 10 breaths per minute and compression rate is 100 to 120 per minute. So if you have intubated the patient, advanced life support means you have intubated the patient. So for an intubated patient, compression rate is 100 to 120 compressions per minute, while respiratory rate for children is very important change. So you can expect a question is 20 to 30 per minute, while for adults previously it was also 10 and now also 10. Means if you are doing CPR, one person will continue compression at a rate of 100 to 120 per minute, and second person who is giving breathing, if the victim is an adult, he will give breath after every 6 seconds, while if the victim is a child, it will give breath after every 2 to 3 seconds, 20 to 30 per minute. Fine. So this is very important. Now the question here is 20, 25, 30 both. Then what you will do? So if it is a child, then you select a rate of 25, but if it is an infant, then you select a rate of 30. So in our case, it's a 5-year-old child, so we'll be selecting 25. So answer is C. And that's it. I think these are some of the very important recent advancement and important questions for your FMGE based on your recent advancement and by looking at the trend, how they're asking the questions. Later also, if any query, you can post her on eGurukul Facebook, and there are many, your groups are there. You can post on that, and then they post to us, and then we try to solve your queries as far as possible, as early as possible. So thank you very much. Thanks for attending, and my real best wishes.